Imagine walking into a clinic feeling, perfectly fine,
Right.
but there's this painless white smudge on the side of your tongue. And that tiny little smudge tells the physician that your entire immune system is quietly collapsing.
It's a terrifying thought, honestly.
It really is. So welcome to the deep dive, everyone, to their mucous membranes broadcast the microscopic systemic realities of immune failure.
Specifically, we're looking at this in the context of HIV and AIDS.
Exactly. And to anchor this, we've got a really fascinating piece of source material. It's a dense, highly technical question from a 2006 dermatology board exam.
Yeah, from Fumark in Brazil.
Right. And our mission today is to decode this exam question, uncover the realities of HIV dermatological manifestations, and, well, extract all the medical and historical insights packed into this one single clinical puzzle.
It really is the perfect vehicle for this kind of discussion.
Okay, let's unpack this. Because a medical board question of this caliber isn't just a memory test.
Oh, not at all. It's a gauntlet of complex virology. The physician taking this test is forced to differentiate between entirely distinct pathophysiological pathways.
Like viral latency, cytokine dysregulation, and viral oncogenesis.
Right. And all of these are manifesting simultaneously on the boundary organ that we call the skin.
So let's look at the exact hurdle these doctors had to clear. I'm going to read the central question.
Go for it.
It asks the candidate to evaluate 4 highly specific statements regarding HIV infection and AIDS and identify the single exception.
So they have to find the incorrect statement.
Exactly. It's a test of identifying the diagnostic imposter, basically. So here are the 4 scenarios.
Okay.
Option A says, oral hairy leukoplakia usually causes severe local pain. Option B says, pruritus or itching is a common complaint in advanced AIDS patients.
Right.
Option C says, Kaposi sarcoma in AIDS patients is not frequently a direct cause of death. And option D is a mouthful. It says, HIV-associated eosinophilic folliculitis shows neutrophilic and eosinophilic inflammatory infiltrates in hair follicles on anatomopathological examination.
Wow. You can really see the cognitive load this places on the diagnostician.
I mean, yeah. It's intense.
You got leukoplakia driven by an opportunistic virus, severe pruritus driven by immune dysregulation, a vascular sarcoma driven by viral oncogenesis, and then that hyperspecific inflammatory infiltrate.
Just finding the clinical error requires this really deep mechanistic understanding of how each condition interacts with host tissue.
Which brings us to the correct alternative to select.
Yeah.
The lie hiding in the lineup.
And it is option A.
Yes.
The statement that oral hairy leukoplakia usually causes severe local pain is completely factually false.
Exactly. Our sources, which reference standard WHO and clinical infectious disease guidelines, are absolutely adamant about this.
But the reason it's false is what's really interesting here, right? Because it reveals a profound difference between types of infections.
That is the core of the clinical justification. Oral hairy leukoplakia is characteristically asymptomatic.
Meaning it doesn't trigger the pain receptors in the mouth at all.
Not one bit. The trap, the examiner said, relies on this basic assumption that a visible textured plaque on the tongue must inherently cause friction or burning.
Which makes sense intuitively. Wait, though, it's called a hairy plaque. Doesn't that feel irritating to the patient? Like hair in your mouth?
That's the trick. The hairy description is microscopic. It refers to the vertical corrugations on the lesion, not actual hair.
Oh, wow, okay.
And the patient often doesn't even know it's there because the lesion is driven by the Epstein-Barr virus, or EBV.
And EBV doesn't just sit on the tongue irritating it, right?
Exactly. It fundamentally subverts the host's own cellular machinery.
Right, so this isn't an exogenous invasion like a fungus or a bacterial biofilm just sitting on top of the tissue.
No, this is endogenous subversion. The Epstein-Barr virus gets inside the epithelial cells of the tongue and alters their replication cycle.
So that hairy appearance, those corrugated vertical ridges, that's literally the host's own hyperkeratinized skin cells just stacking up.
Yes, because the virus is forcing them to overproliferate.
And it doesn't hurt because the body doesn't recognize its own altered tissue as an injury.
Precisely. The virus is essentially remodeling the house from the inside out, and the alarm system doesn't trip because the virus possesses the host's own physiological key.
What's fascinating here is how a completely painless plaque serves as this massive biological alarm bell.
It really does. Guidelines dictate that the appearance of oral hairy leukoplakia correlates tightly with a CD4 positive T lymphocyte count dropping below 200 to 300 cells per cubic millimeter.
Which means the systemic immune surveillance has completely failed.
Exactly. The clinic is sovereign here. The physical exam yields a systemic diagnosis without initially even requiring a blood draw.
And the sheer scale of this phenomenon is staggering, honestly.
It is. The epidemiological data in the sources indicates nearly 90% of AIDS patients will develop dermatological manifestations.
90%. So for many, it's the very first clue of their seropositive status.
Right. Because the skin isn't just a passive wrapper. It's an active, immunologically dense boundary organ, teeming with Langerhans cells and resident memory T cells.
So when the systemic CD4 count crashes, the skin becomes the primary battleground.
To understand the etiology of these manifestations, we really have to look at the transition from acute infection to latency.
Okay, let's take that Epstein-Barr virus we just discussed.
Good example. The vast majority of the population actually acquires EBV in adolescence.
Wait, really?
Yeah, it manifests as infectious mononucleosis, the kissing disease.
Okay, that's wild. How does a common teenage virus turn into a marker for advanced immunosuppression?
Well, initially your immune system mounts a massive CD8 cytotoxic T cell response, controls the acute infection, and you recover.
But the virus isn't gone.
No, it establishes lifelong latency within memory B cells and the basal epithelial cells of the oropharynx.
So it just integrates its episomal DNA into the host nucleus and silences its own viral protein expression so it can evade detection.
Exactly. And your immune system maintains this constant, really metabolically expensive perimeter guard around these latent infected cells.
Okay, so when the HIV retrovirus comes in and selectively depletes the CD4 helper T cells, the cells that coordinate that guard, what happens?
The EBV senses the lack of immune pressure. It flips its genetic switches from latent to lytic replication.
And that Y-lytic replication in the lateral borders of the tongue is what creates the leukoplakia.
You got it. But the loss of CD4 cells doesn't just allow latent viruses to reactivate. It throws the remaining immune network into absolute chaos.
Right, which brings us to the underlying mechanisms of the other conditions mentioned, pathophysiologically speaking.
Like eosinophilic folliculitis. It's a prime example of systemic immune confusion.
Because there's no opportunistic virus driving the folliculitis, right?
Correct. The sources point to what we call a Th2 shift.
Okay, what is that exactly?
Well, without the CD4 regulatory oversight, the immune system basically defaults to an anti-helminthic or anti-parasite cytokine profile.
It's a systemic dispatch failure.
Exactly, the dispatch failure analogy. The body starts pumping out interleukin-4 and interleukin-5.
And those are specifically designed to recruit and activate eosinophils, right?
Right, so the body is essentially deploying heavy artillery designed to dissolve multicellular parasites, but there are no parasites present.
Oh man. So where do these eosinophils go?
They traffic to the sebaceous glands and hair follicles. They react to the normal commensal flora of the skin, the bacteria, and yeasts like Malsacia that usually just live there peacefully.
So the eosinophils infiltrate the follicle and degranulate. They release major basic protein and eosinophil calcinic protein directly into the tissue.
And those proteins are highly cytotoxic. They destroy the local architecture of the hair follicle.
But they also trigger an agonizing side effect.
Yes. When the sources say pruritus or intractable itching is a hallmark of advanced AIDS, it's not just dry skin.
Right. These inflammatory mediators, along with neuropeptides like substance P, are directly binding to the free nerve endings in the epidermis.
It causes a continuous unyielding transmission of itch signals to the dorsal horn of the spinal cord.
It sounds like a relentless neurological burn.
It really is. The patient gets trapped in a cycle of intense pruritus and subsequent excoriation. They scratch until they bleed.
Which then opens the door for secondary bacterial infections like Staphylococcus aureus.
Exactly. It's a compounding pathophysiological disaster. Now, contrast that inflammatory chaos with the highly targeted viral oncogenesis of Kaposi sarcoma.
Right, which is driven by human herpes virus 8 or HHV8. Kaposi's operates on a totally different wavelength.
Completely different. HHV8 infects the endothelial cells lining the blood and lymphatic vessels.
But it doesn't just destroy them, does it?
No. The virus expresses a suite of proteins that mimic the host's own cellular signaling molecules.
So it produces a viral homolog of interleukin 6, and it aggressively upregulates vascular endothelial growth factor, or VEGF.
And upregulating VEGF forces the infected endothelial cells to undergo a radical morphological transformation.
Meaning they lose their typical cobblestone shape and become elongated spindle cells?
Exactly. But more importantly, the VEGF drives chaotic, unchecked angiogenesis.
Angiogenesis, that's the creation of new blood vessels.
Right. The virus essentially hijacks the host's vascular scaffolding to build its own microenvironment.
Wow. Resulting in those dense, tangled, leaky vascular tumors that present clinically as purpuric or violaceous nodules on the skin.
Yes. So look at what we have here. We have an oral plaque driven by viral subversion, itchy follicular papules driven by cytokine dispatch errors, and purple vascular tumors driven by viral angiogenesis.
If you are the attending physician, your diagnostic approach has to be incredibly precise because visual overlaps can be lethal.
Let's look at the expanded clinical judgment required here, starting with those oral lesions.
Okay, so if a patient presents with a white plaque on the lateral tongue, you have to definitively rule out Candida albicans, which is standard fungal thrush.
Right. And the immediate bedside diagnostic differential for that relies on the scrape test.
The scrape test, how does that work?
Because Candida is a fungal organism that forms a pseudomembranous mat over the mucosal surface. It's physically just sitting on top of the epithelium.
So if you take a tongue depressor and apply firm pressure,
the candle plaque will shear off. It leaves an erythematous raw and often bleeding base underneath.
But as we established, oral hairy leukoplakia is the host's own hyperkeratinized epithelial cells. You cannot scrape it off.
Exactly. If it shears away, it's an exogenous fungus. If it remains fixed, it's an endogenous viral alteration.
And that physical differentiation dictates whether you prescribe an antifungal like fluconazole or if you immediately escalate their antiretroviral regimen.
Yes. And that level of diagnostic nuance is even more critical when differentiating Kaposi's sarcoma from its primary mimic, bacillary angiomatosis.
I read about this in the sources. The visual overlap is uncanny.
It really is, both present as eruptive vascular red to purple nodules in immunocompromised patients.
But the underlying plumbing is entirely different because bacillary angiomatosis is a bacterial infection.
Right, caused by the Bartonella species, usually transmitted by cat scratches or body lice.
Which is fascinating. You have a bacterial infection mimicking a viral cancer.
And it mimics it by driving a parallel angiogenic pathway. Bartonella also induces endothelial cell proliferation, but through totally different molecular triggers.
So to the clinical eye, how do you tell them apart?
Well, bacillary angiomatosis lesions tend to be more erythematous redder and exquisitely friable.
Friable meaning easily crumbled or broken.
Exactly. Because the newly formed vessels are so poorly constructed, the slightest touch can cause them to hemorrhage.
Whereas Kaposi's lesions, while vascular, are true neoplasms.
Right. They're typically firmer, more violaceous, and much less prone to spontaneous bleeding.
So the definitive diagnostic ladder here requires histopathology. You have to biopsy the lesion.
You do. If the pathologist sees Wharton starry silver stain positive bacilli, you have Bartonella.
And then you just treat it with simple macrolide antibiotics like erythromycin, and the vascular tumors literally melt away.
Exactly. But if you mistake it for Kaposi's and initiate systemic chemotherapy,
you plunge an already immunocompromised patient into severe toxicity for absolutely no reason, while the bacterial infection just rages on.
It's a huge error. This is why the standard of care involves confirming the syndromic presentation with definitive laboratory testing.
Like HIV viral load assays, CD4 counts, and tissue biopsies.
Right. And for Kaposi's, the diagnostic imaging must extend beyond the skin. The guidelines actually mandate a pulmonary and gastrointestinal workup.
Often requiring a chest x-ray and an upper endoscopy because the HHV8 virus doesn't limit its vascular hijacking to just the epidermis.
Exactly. Visceral Kaposi's can line the bronchial tree or the mucosal surface of the stomach.
So a patient could look totally stable cutaneously, but be on the verge of massive internal hemorrhage or respiratory compromise.
Yes, from pulmonary infiltrates. And the location of these lesions is highly non-random, which brings us to the anatomotopographic approach.
Right, we mentioned earlier that oral hairy leukoplakia overwhelmingly favors the lateral borders of the tongue.
This isn't just a quirk, it's a direct result of microanatomy.
Because the lateral borders have a significantly lower density of fungiform and filiform papillae, the taste buds, compared to the dorsal surface.
But more critically, the sides of the tongue are subjected to relentless microtrauma.
Oh, like every time the patient speaks, chews, or swallows, that lateral tissue is subjected to shearing forces against the teeth.
Against the molars, exactly. That constant mechanical friction necessitates a really high rate of basal cell turnover to repair the microscopic damage.
And any tissue undergoing rapid cellular proliferation is an incredibly attractive target for a virus looking to hijack the replication machinery.
Precisely. The physical wear and tear of daily life creates the exact microenvironment required for EBV reactivation.
That makes perfect sense. And we see a similarly specific spatial relationship with Kaposi's sarcoma, don't we?
We do. While it can erupt anywhere, it frequently maps itself along Blaschko's lines.
Now, to the uninitiated, Blaschko's lines sound like medical astrology, like invisible tiger stripes on human skin.
It does sound like that.
Right.
But they are actually a map of our own embryogenesis.
Right. They represent the pathways that embryonic epidermal cells migrated along during fetal development.
Because of a phenomenon called somatic mosaicism, different clones of cells map out distinct territories on the skin, and latent viruses often track along these developmental fault lines.
But more specifically, Kaposi's has a notorious predilection for the hard palate in the oral cavity, the roof of the mouth.
Yes.
Why does the HHV8 virus preferentially target the hard palate?
It comes down to the specific lymphatic architecture. The mucosal lining of the hard palate contains a dense, specialized network of lymphatic endothelium. And these specific endothelial cells possess an extremely high density of the exact receptors that the HHV8 virus uses for entry and subsequent VEGS signaling.
It's a biological lock and key mechanism.
Exactly. Meaning the palate is uniquely primed to respond to the virus's angiogenic stimuli.
So what does this all mean? The physical location of the lesion provides a direct window into the microscopic vulnerabilities of the tissue.
Beautifully put. And understanding these mechanisms dictates the therapeutic approach. Because you don't cure oral hairy leukoplakia by trying to surgically excise the plaque.
Right, the virus is systemic. If you cut it out, it'll just reactivate elsewhere.
The foundational therapy, the master switch, is antiretroviral therapy, or RT.
The objective is to aggressively suppress HIV replication, driving the viral load to undetectable levels.
Right. This relieves the pressure on the bone marrow, allowing a profound reconstitution of the CD4 T cell population.
You essentially bring back the immune system's regulatory oversight.
And once those newly minted CD4 cells traffic to the peripheral tissues, they recognize the EBV expressing intralytic proteins on the tongue.
And they recognize the HHV8 expressing oncogenic proteins in the endothelium.
Exactly. They mount a targeted cytotoxic response, and the lesions frequently undergo spontaneous regression.
However, that process of immune reconstitution is fraught with danger, isn't it?
It is. It can lead to what is known as immune reconstitution inflammatory syndrome, or IRIS.
IRIS. So mechanistically, you're taking a severely immunocompromised body that's heavily burdened with subclinical latent pathogens.
Like widespread mycobacterium or pervasive HHV8. Yeah.
And you suddenly infuse it with millions of functionally competent, antigen-naive, and memory T cells.
It's a massive systemic shock. The newly restored immune system suddenly sees this massive pathogen load that the body has been ignoring for months or even years.
And it triggers a profound, uncoordinated cytokine storm,
flooding the system with tumor necrosis factor alpha and interferon gamma.
The resulting inflammation can be devastating.
Truly, a patient's previously stable flat Kaposi's lesions might suddenly swell, become highly erythematous, and just proliferate aggressively.
It's a paradoxical worsening of clinical symptoms, and it's driven entirely by the recovering immune system trying to do too much, too fast.
Managing IRIS often requires delicate titration of corticosteroids alongside the RT. You have to suppress the destructive inflammation while allowing the immune system to rebuild.
And while waiting for the RT to take effect, the symptomatic management of these conditions is intense.
Very. For the eosinophilic folliculitis and that intractable pruritus we talked about, topical corticosteroids are used to suppress the localized follicular inflammation.
But dermatologists also utilize narrowband UVB phototherapy.
Yes. The physics of this are really fascinating.
The sources mention a specific 311 nanometer wavelength of ultraviolet light.
Right. That specific wavelength penetrates the epidermis and directly induces apoptosis programmed cell death in the hyperactive T cells and eosinophils localized in the skin.
Without causing systemic immunosuppression.
Exactly. It's localized immunological silencing.
Now, to bring us back to the clinical reasoning of the exam question, We have to perform a final analysis of the other alternatives to understand why they were factually correct statements.
Okay, let's reevaluate option C.
Option C stated, Kaposi's sarcoma in AIDS patients is not frequently a direct cause of death.
This requires a clear-eyed look at the natural history of untreated HIV. While Kaposi's is a disseminated vascular neoplasm and cosmetically and psychologically devastating, the cutaneous lesions are rarely lethal in themselves.
The morbidity is high, but the mortality is low. Unless, as we discussed, there is massive visceral involvement leading to pulmonary hemorrhage.
Right. The real killers in advanced untreated AIDS were the opportunistic infections that targeted the central nervous system and the deep pulmonary tissue.
Like pneumocystis jirovecii pneumonia causing slow asphyxiation.
Or Toxoplasma gondii causing necrotic abscesses in the basal ganglia of the brain.
So the exam requires the physician to know that the purple lesions on the skin, while alarming, are often secondary threats compared to the silent internal fungal and parasitic invasion.
Absolutely. And option D perfectly described the histopathology of eosinophilic folliculitis.
Right, demonstrating neutrophilic and eosinophilic infiltrates in the hair follicles.
If you biopsy the lesion, the microscope reveals exactly what the Th2 cytokine shift predicted. A dense crowd of degranulating eosinophils destroying the sebaceous architecture.
And then option B stated that pruritus is a common complaint.
Which, as we exhaustively mapped out with the neurological pathways of that itch, is a absolute hallmark symptom.
So the diagnostic imposter remains option A, the false claim that oral hairy leukoplakia is painful.
If we connect this to the bigger picture, the systemic collapse of cellular immunity and the subsequent rise of opportunistic pathogens is not an exclusively human tragedy.
No, the sources actually delve into the secrets of the animal kingdom, and the comparative immunology is revelatory.
It really is. It proves that the biological mechanisms of retroviral pathogenesis are highly conserved across mammalian evolution.
Let's look at the domestic cat, Felis catus.
Yeah, Felis catus suffers from the feline immunodeficiency virus, or FIV.
Which is feline AIDS, essentially.
Structurally and functionally, FIV is remarkably similar to HIV. It exhibits a distinct tropism for the cat's CD4 equivalent T lymphocytes.
And as the viral load increases and the lymphocyte count falls, the feline immune system fails in a pattern almost identical to human AIDS.
And the dashboard warning lights are the same. A primary clinical indicator of FIV is severe oral opportunistic infection.
Right, cats develop intractable gingival stomatitis.
Massive, painful inflammation of the oral mucosa and gums, driven by an inability to manage the bacterial flora of their own mouths.
So oral health as a sentinel for systemic immune health really crosses species lines.
It does, but the most vital evolutionary data comes from non-human primates.
Specifically, sooty mangabees and certain species of chimpanzees, pantroglodytes.
These primates are natural hosts for the simian immunodeficiency virus, SIV, which is the direct evolutionary precursor to HIV.
This is where the evolutionary biology gets incredible.
It's mind-blowing. These primates can be infected with SIV, carrying viral loads that will be rapidly fatal in a human. We're talking billions of viral RNA copies per milliliter of plasma, and yet they do not develop AIDS.
Wait, really? Their CD4 counts remain stable?
Yes, their immune systems do not collapse. It is the phenomenon of natural host tolerance, and it is the holy grail of current HIV research.
But humans and rhesus macaques who do get sick from SIV react to the virus by mounting a massive chronic immune response.
Exactly. Our immune system stays locked in a state of hyperactivation, constantly churning out T cells to fight a virus it cannot clear.
And this chronic activation is what ultimately exhausts the bone marrow, drives the CD4 depletion, and destroys the lymphoid tissue architecture.
We literally burn our own house down trying to kill the virus.
But the natural hosts, the mangabees, have evolved a totally different strategy.
Over hundreds of thousands of years of coevolution, they have downregulated the expression of the CD4 receptor on certain critical subsets of their immune cells.
More importantly, their immune systems recognize the virus early on, but then they actively suppress the inflammatory response.
They establish a truce. The virus replicates, but the host's immune system just ignores it, avoiding the chronic hyperactivation that causes the actual immunodeficiency.
And understanding how to artificially induce that state of immunological tolerance in humans is the foundation for researching functional cures right now.
Absolutely. And to study this, scientists rely on another incredible animal model mentioned in the sources, Musculus, the laboratory mouse.
But a standard mouse cannot be infected with HIV, right? Because its cells lack the specific human CD4 receptor and the CCR5 co-receptor required for viral entry.
Right, so biological engineers created the humanized mouse, specifically the BLT mouse model.
BLT stands for bone marrow, liver, thymus.
Scientists heavily irradiate the mouse to ablate its own immune system and then surgically implant human fetal thymus and liver tissue, followed by an infusion of human hematopoietic stem cells.
It is breathtaking science. The stem cells migrate to the implanted human thymus, mature into functional human T cells, and populate the mouse's lymphatic system.
You essentially build a functioning human immune system inside the biological chassis of a mouse.
And because it possesses human CD4 cells, this mouse can be infected with human HIV.
Researchers can then track the pathogenesis of the virus in vivo, test novel antiretroviral compounds, and literally watch the Th2 cytokine shift orchestrate the infiltration of eosinophils into the skin.
The leaps in molecular biology required to engineer a BLT mouse, or to map the genetic sequences of SIV across primate species. It all relies entirely on foundational discoveries that shattered the scientific consensus of their time.
It really does. The medical knowledge embedded in the single 2006 few mark exam question is built on the backs of multiple Nobel Prize laureates.
It's impossible to overstate how revolutionary these discoveries were.
Prior to 1975, the central dogma of molecular biology was absolute. Genetic information flowed strictly in one direction.
DNA transcribed to RNA, which translated to protein.
The idea that RNA could flow backward to alter cellular DNA was considered biological heresy.
But the 1975 Nobel laureates David Baltimore, Renato Dulbecco, and Howard Timmon shattered that dogma.
They discovered the enzyme reverse transcriptase inside certain tumor-causing viruses.
They proved that these viruses carry an enzyme capable of taking viral RNA and reverse engineering it into double-stranded DNA, which is then permanently integrated into the host's genome.
And HIV is a retrovirus. The retro defines its use of reverse transcriptase.
Without the biochemical framework established by Baltimore and Timmon, we would never have understood how HIV establishes permanent latency inside the CD4 cell's nucleus.
Furthermore, the very first successful antiretroviral drug, AZT, was a reverse transcriptase inhibitor. The entire foundation of modern HIV survival is built on their discovery.
Fast forward to 2008, the Nobel Prize was awarded to Françoise Barré-Sinoussi and Luc Montagnier for the actual isolation of the human immunodeficiency virus itself.
In 1983, while the world was panicking over a mysterious syndrome causing Kaposi sarcoma and pneumocystis, they cultured cells from the swollen lymph node of a patient and observed the classic cytopathic effect of a novel retrovirus.
They identified the exact biological agent responsible for the CD4 depletion.
But the 2008 Nobel Prize was split. The other half went to Harold Zerhausen, and his inclusion perfectly completes the pathophysiological loop we've been discussing today regarding viral oncogenesis.
Because Zerhausen spent the 1970s and 80s arguing against the entire medical establishment.
The consensus at the time was that herpes simplex virus 2 caused cervical cancer.
Zerhausen looked at the data and disagreed. He hypothesized that the human papillomavirus HPV was the true oncogenic agent.
He faced immense skepticism, but using novel DNA hybridization techniques, he managed to isolate HPV 16 and 18 DNA directly integrated into the genome of cervical tumor biopsies.
He proved that a viral infection could synthesize specific proteins E6 and E7 that bind to and degrade the host's tumor suppressor genes, driving the cell into uncontrolled cancerous replication.
He proved that viruses can cause human cancer by manipulating the cell cycle.
And his conceptual breakthrough with HPV provided the exact intellectual framework necessary for virologists years later to discover HHV8
and understand precisely how it drives the proliferation of Kaposi sarcoma in AIDS patients.
So, to trace it all back, the reverse transcriptase allows the retrovirus to hide. The retrovirus destroys the immune system. The broken immune system allows oncogenic viruses to reactivate. And the oncogenic viruses manipulate cellular genetics to cause vascular tumors.
It is a devastating biological cascade mapped out across decades of Nobel-winning science.
And it all crystallizes in the clinic when a physician looks at a complex presentation of dermatological manifestations and has to make the right diagnostic call.
Which is why we need to distill this massive volume of pathophysiology into a final summary of clinical management and guidelines.
For the practitioner or the student listening, here are the core takeaways.
First, dermatological manifestations in the context of HIV are the ultimate proxy for systemic immune health. The physical presentation correlates tightly with absolute CD4 counts.
Right, and here are your key points. Oral hairy leukoplakia is driven by Epstein-Barr virus.
It favors the lateral borders of the tongue due to microtrauma.
It cannot be scraped off. And crucially, it is asymptomatic and painless.
Kaposi's sarcoma is driven by human herpes virus 8. It is a vascular neoplasm driven by viral angiogenesis.
It presents as firm, violaceous nodules. It frequently targets the hard palate, and while cosmetically severe, it is rarely the direct cause of death unless there is visceral pulmonary or gastrointestinal involvement.
Eosinophilic folliculitis represents a systemic Th2 immune shift. It is characterized by intensely pruritic, itchy follicular papules, and biopsies reveal dense infiltrates of eosinophils and neutrophils.
The primary intervention for all of these is the immediate initiation of antiretroviral therapy to suppress viral replication and reconstitute the CD4 population, keeping a vigilant eye out for immune reconstitution inflammatory syndrome.
And for those facing board exams, the sources offer some vital mnemonics and pitfalls to avoid.
Oh, I love the lazy plaque mnemonic for oral hairy leukoplakia. It's lazy because it just sits there.
Right, it doesn't cause pain, it doesn't bleed, it doesn't scrape away. It simply exists as a passive alarm bell for a low CD4 count.
The absolute diagnostic trap is seeing the words removable by scraping or painful burning sensation. If you see that on a test, you are dealing with candida fungal thrush, not leukoplakia.
And for differentiating the vascular lesions, remember the two Ks, K for Kaposi and K for Kelvin, the unit of temperature.
So Kaposi's lesions are conceptually cold. They are firm, purplish, true neoplasms that do not easily bleed.
Contrast this with bacillary angiomatosis, which is conceptually warm, erythematous, inflamed, highly friable bacterial lesions that hemorrhage upon contact.
Kaposi is cold and firm. Bartonella is warm and friable. That distinction alone saves a patient from unnecessary chemotherapy and guides them toward a simple antibiotic cure.
We have traversed an immense amount of biological terrain today, from the friction on the lateral tongue to the evolutionary genetics of the mangabey monkey.
It really highlights the sheer density of information that clinical medicine requires. The skin and the mucous membranes are not just a covering, they are a high-fidelity display of our internal virological and immunological wars.
The fact that we have mapped these mechanisms down to the specific cytokine and receptor level is an astonishing human achievement.
But the journey is far from over. We understand the retrovirus and we can force it into deep latency with art, but we cannot excise it from the genome. I want to leave you, the listener, with a final provocative thought regarding the animal kingdom we discussed.
This raises an important question.
We looked at the chimpanzees and the sooty mangabeys, carrying billions of copies of SIV in their bloodstreams without ever developing immunodeficiency. Over evolutionary timescales, they haven't found a way to destroy the virus. They found a way to tolerate it.
They achieved a peaceful biological truce, downregulating their immune response to avoid the very inflammation that causes AIDS.
If millions of years of primate evolution solved the retrovirus problem, not through eradication, but through immunological homeostasis, what does that mean for the ultimate future of human medicine? Perhaps the ultimate cure for HIV isn't a sharper pharmacological weapon designed to hunt down every last latent reservoir. Perhaps the true cure lies in teaching our own hyperreactive immune systems how to draft a treaty. Keep reading the dashboard.